Hi everyone, our group consists of Samson, Jessica, and Carrie. Today we'll be looking at a case regarding self-management in dementia from an interdisciplinary perspective. The challenges dementia patients, their families, and healthcare providers face, and some recommendations to facilitate the self-management of dementia. When we started working on this case study assignment, we wanted it to be as interdisciplinary and interprofessional as possible. We considered each of our areas of dissertation research interests to see if we could find a case that cuts across each of our professional practices. Carrie's research interest is on self-management of chronic disease. Samson and Jessica both work with older adults in long-term care, assisted living, and memory care facilities, and they're used to working with people who have dementia. So we came up with our case study topic that truly cuts across our three areas of interest: self-management, older adults in assisted living, and older adults with a diagnosis of dementia. Formulating this topic gave us a concrete opportunity to work as a team and to utilize our skills learned throughout the course to foster interprofessional collaboration among ourselves. Effective communication through different technology and media were paramount to see the end of the project in this case presentation. So after working together as a team, we're happy to present this case, the Self-Management in Dementia, an interdisciplinary case study. First, let's go over some background information. Dementia is an umbrella term for the multiple diagnoses that result in loss of memory and other cognitive functioning difficulties. It's now the primary cause of disability and dependency among older adults 65 and older, and has been declared a public health priority by the World Health Organization. In the US, there are approximately 6.2 million older adults living with the effects of dementia. These effects range from mild memory loss, loss of language, and lack of orientation to person, place, or time. Despite these effects, or maybe because of them, many adults want to continue to age in place in their own homes with their current social supports. In the early stages of dementia, however, individuals exhibit a mild cognitive impairment, which often results in social and functional changes that can interfere with their ability to stay in their current environment. Dementia is a chronic and progressive condition that affects multiple aspects and activities of daily living for those who live with it.
While dementia is recognized as a chronic condition, literature to date has not focused as much on self-management interventions for patients with conditions involving cognitive impairment like dementia. The chronic care model developed by the McCall Institute for Healthcare Innovation at Group Health Cooperative identifies the essential elements of a healthcare system that encourage high-quality chronic disease care. The model focuses on mobilizing community resources, promoting high-quality care, implementing care consistent with evidence and patient preferences, effectively using patient population data, cultural competence, care coordination, health promotion, and enabling self-management. Self-management support is a key component of the chronic care model and can be an effective strategy to improve care for patients with early-stage dementia. What is self-management? Self-management focuses on an individual's ability to manage their day-to-day lives by participating in social situations and completing activities of daily living. These activities can include taking medications, cooking meals, and cleaning their home. Self-management interventions can allow for dementia patients to have an improved quality of life and be able to remain independent and age at home for a longer period of time. Self-management support of dementia patients also benefits family and caregivers' quality of life. Some examples of self-management interventions are group classes. The Stanford model of chronic disease self-management is one example of a self-management intervention that utilizes group classes for support and education. Skill development is another example of a self-management intervention Ensuring competence and learning new skills for self-management can be a successful approach as well. Oftentimes, self-management requires a behavior or lifestyle change. A health coach can provide individual one-on-one guidance for the patient. And lastly, there are many new interventions using technology to support self-management. Remote monitoring and connecting to healthcare providers and caregivers virtually are some examples of these interventions.
This case is about Harold. Harold is a 71-year-old male living with his wife in a single family home. His wife is 68 years old with severe rheumatoid arthritis and COPD and relies heavily on Harold for assistance with her care. Harold began to have difficulty remembering recent events. He was forgetting where he put things and skipping steps in complex activities of daily living. His three adult children, who live about 3 hours drive away, became concerned about Harold's safety and independence. And 6 months later, Harold's geriatrician for 12 years diagnosed him with early stage dementia. Their oldest daughter began to advocate for Harold and his wife to move to an assisted living facility near her. The children became more concerned about Harold. What if he had a fall and sustained an injury? Who was going to help their mother with her self-care needs? So the children spoke with their mother and with Harold about moving into an assisted living facility. 2 months later, after his diagnosis, Harold and Myrtle, his wife, moved into an assisted living facility near their oldest daughter. Harold's dementia progressed while he was in the assisted living facility. He began to forget names of familiar people and places, and he also got frustrated when someone reminded him of a task he forgot to do. While in the facility, as time went on, Harold also began to withdraw from family gatherings and from social events. Addressing the needs of people with mild cognitive impairments, such as an early stage dementia, requires various stakeholders. In this case, the patient is the primary stakeholder. His wife is also significant because all the decisions that are going to be made for Harold is going to affect his wife, as Harold was her primary caregiver, helping her with activities of daily living. The three adult children are also significant because they care for their parents and they are making decisions to improve their safety and their independence. Dr. White and his medical practice are also significant stakeholders. They are in charge of his medical care. When Harold moved into the assisted living, the management and the direct care staff of the assisted living became significant stakeholders in this case. Understanding and coping with mild cognitive impairment, such as an early stage dementia, is challenging for the patient as well as their families and caregivers. In Harold's case, his family noticed changes in his behavior, such as forgetting recent events, forgetting where he put things, and skipping important steps in self-care activities. Meanwhile, Harold refused to accept that this was happening, and even when diagnosed by his primary care doctor, Harold refused to follow the doctor's recommendations to start self-care management at home, which would have kept him at home for a longer time. Harold and his family did not quite understand the presentations and progression of dementia, so they panicked. They were afraid. This lack of understanding could be seen in their confusion and conflicts about rushing Harold's relocation and totally altering their living arrangements.
The second challenge in this case was the lack of follow-up of Dr. White and his office. Even though self-management strategies were discussed, it does not mean the recommendations were followed through with. Almost 1/3 of primary care provider patients are referred to specialty care services. Despite provider referrals, approximately 1 in 4 referrals are never completed. incomplete referral rates are higher among vulnerable individuals. There can be many barriers for patients in following up with these referrals and/or treatment recommendations. We already know in Harold's case that he is in denial of his diagnosis and thinks he is fine. He may have also been confused about what needs to be done. Coordinating care with different providers in new places can be overwhelming. There also can be barriers around social determinants of health, such as finances, finding transportation to and from these appointments, family support, and really even having enough time to be able to manage the disease. There were opportunities for Dr. White's office to follow up on Harold's case, but Dr. White did not have a formal policy in place for following up with patients to ensure treatment recommendation was completed. So there is often confusion of whose responsibility it was. The roles and responsibilities of staff and physicians were not defined. And they needed to be more aware of resources to respond to patient requests to successfully manage patient referrals.
Harold's family was not in agreement regarding his living situation and what the best plan was moving forward. Every stakeholder brought a different perspective. As we discussed, the first challenge of this case revolved around the lack of understanding of what dementia is and how it progresses. This lack of understanding, as well as each individual's perspective, led to the disagreement of where Harold and Myrtle should live. Harold, who was in denial that he even had dementia, saw no reason to change his lifestyle or to move to be closer to family supports. Myrtle already had established healthcare providers in the area and was reluctant to move and start that process all over again. However, she felt that Harold would not be able to assist her as much as he always had, and she would not be able to assist him as much as he was going to need. June, the oldest daughter, wanted her parents to move closer to her right away so that she could help care for Myrtle as Harold was no longer able to. June also felt that her parents should move into a long-term care facility so that there was always someone around just in case. Finally, Dr. White felt strongly that Harold and Myrtle should remain at home and begin to implement self-management strategies. While all of these perspectives are valid options for a person living with dementia, these stakeholders never came together as a whole to decide what was best for this situation. Instead, June continued to advocate for what she felt would be best for her and finally convinced her parents to move.
The person-environment fit theory is a great framework to guide our understanding of behavior changes in early-stage dementia. The basic assumption about this theory is that people have an innate need to fit in their environment or to choose environments that fit their need. In this case, the person and the environment should be a match. The theory focuses on the interaction between the characteristics or competencies of the individual, such as motor control, muscle strength, cognitive capacity, values, and overall health of the individual, and the characteristics of the environment, which can include the demands of the task, the role, the cultural values, other individuals, and social factors. As people get older, there are also changes in their ability to perform tasks within their environment. So people with dementia go through changes in their ability to function within their environment. Therefore, self-management interventions can help people with dementia cope and live longer in their homes or in their chosen environments.
The social cognitive theory states a person's behavior is influenced by his or her goals, level of self-efficacy, outcome expectations, and sociocultural factors. Self-efficacy, the belief that an individual can perform an action or task in certain situations, is the aspect of social cognitive theory that relates most to self-management. Self-management can improve quality of life and clinical outcomes for people with chronic conditions, particularly if the intervention focuses on behavior change and enhancing self-efficacy. Another theory playing a role in self-management is the theory of self-determination. Self-determination theory grew out of the work of psychologists Edward Deci and Richard Ryan in 1985. The theory states that human behavior is driven to meet the three basic needs of competence, autonomy, and relatedness. If these needs are met, motivation is increased. If they are not met, motivation is thwarted. In an article by Dixon in 2021, we are reminded that self-management interventions should remain patient-centered so as not to decrease the patient's feeling of autonomy and undermine their self-determination. Many advances are happening in technology and healthcare, such as using Alexa, for example, to set daily reminders for patients. These technological interventions are helpful and are being designed to include the patient along the way. This theory empowers patients to be active agents in their own healthcare.
Now that we've covered the theories that are related to self-management, we wanted to go into some specific recommendations when it comes to self-management of dementia. Research suggests that there are 6 factors that are going to contribute towards introducing these models of self-management. These include early disclosure of the diagnosis, support with the consequences, focusing on the needs of the person with dementia, identification of interventions that may facilitate self-management, meeting the needs for professional education and support, and a whole system approach towards treatment and care. When we focus in on the early disclosure of diagnosis, what this really means is diagnosing the disease early. There really isn't sufficient evidence to recommend for or against screening for cognitive impairment. However, there are a lot of reasons that this might be important. Anytime someone is experiencing a cognitive impairment, they're going to feel a direct burden from that loss of function. This may impact their financial situations, it can affect their ability to follow medical recommendations, or even strain their close relationships. An early diagnosis allows the patient to plan for these impacts and seek treatment that might maintain their current cognitive function for longer than it would without treatment. This also allows the patient to begin to come to terms with their diagnosis. Often patients who have a mild cognitive impairment do not realize that they do until the symptoms become so severe that those around them are noticing them. Once a diagnosis of dementia has been made, it's important to assess the individual's needs to determine the type of intervention that they would benefit from. A provider who's involved in the diagnosis might consider using the Camberwell Assessment of Need for the Elderly, or the CANE. The CANE is an assessment in which the individual with dementia, or proxy if needed, can rate their unmet and met needs across a variety of contexts. These contexts include things like accommodations, household skills, safety, money, and memory. The CANE can also be completed by a caregiver in order to shed light on any areas the individual with dementia might have poor insight into. The CANE can be administered by any member of the medical team. Because of this, it can be easily re-administered in the future to track any change in the patient needs over time. It may be important to further look at the individual with dementia's needs by assessing their activities of daily living. Instrumental activities of daily living are complex everyday tasks requiring multiple step directions, such as cooking and managing finances. These complex tasks often require compensatory strategies so that the individual can complete them efficiently. The Instrumental Activities of Daily Living Compensation Scale assesses these complex activities in order to capture and quantify the person's compensatory strategies already being used when completing these tasks. Once the care team understands what compensatory strategies are in place, it is easier to plan for future interventions. This tool can also be used to compare scores before and after compensatory strategies are developed to monitor progress and make informed decisions regarding the individual with dementia's environment. Once the individual with dementia's needs are well understood, a collaborative care model can be implemented to help manage the patient's dementia and facilitate self-management. One possible model is the Aging Brain Care Medical Home Model. In this model, a care manager tailors and facilitates the delivery of an established plan of care to individual patients in collaboration with the primary care physician. This type of model will directly impact the second challenge of physician follow-up from the case discussed today. So far, we have discussed various models and strategies that help support self-management of dementia. Now I want to talk about a specific type of intervention that can be used when planning a self-management technique. Future proofing is a highly individualized intervention that each individual with dementia creates for themselves and then carries out to meet their current needs and maintain independence, as well as full participation in the future. We know that patients with dementia will eventually lose the ability to learn new skills, so it's important that they not rely on memory in most situations. Future proofing centers around the idea that an individual with dementia will create and implement strategies that could assist them in their activities of daily living before they need them. These might include things such as Alexa prompting them that they need to take their medicine. It could be using sticky notes around the house as reminders, or any other type of system that will aid their memory. The important thing with future proofing is that the individual implements this before they need it. So before they need those memory aids, they're going to be using them, implementing them into their daily lives. That way it's part of their routine and hopefully preserved as their cognition continues to decline. Like most things, it's important to measure the effectiveness of any strategy after it's implemented. The Partners in Health scale is a scale that's used to measure chronic disease self-management from the primary care setting and can be used with dementia. This allows all members of the care team to assess the individual with dementia's self-management needs so that they can adjust and add or remove supports to further facilitate self-management skills. This will also allow the team to track changes over time.
So we wanted to take a look at the case and see what was done and what should have been done. First of all, we saw that there was lack of patient and family knowledge about mild cognitive impairment and early stage dementia. It's important to improve the patient and family's understanding of early stage dementia by providing education about the disease and its progression and its management. We also saw that Harold refused to comply with Dr. White's orders. So best practice calls for adherence to doctor's orders and doctor's recommendations, and also to begin treatment early when it comes to dementia. Um, the family's three adult children were only insisting that Harold and his wife should relocate to an assisted living. They didn't consider the other parts of treatment, such as medications and therapy at home. It is important that patients and their family adhere to the doctor's recommendations, take their medications, perform therapy, and other self-management interventions that would improve their chances of aging well at home in place for as long as possible, not just rush to an assisted living facility or long-term care facility within 2 months of diagnosis. We also saw that Dr. White never followed up to check on Harold. It is important for doctors to follow up, especially when a patient is going through denial or confusion about the disease. So the doctor and his staff should follow up and check on the patient and his family to provide help where needed. Also, we saw that there were no healthcare professionals that went to Harold's home to provide home health care, clinical care. So no standardized outcome measures were used, and there was no way to measure Harold's dementia at any point. It is important to have all the clinical professionals come to the home, do an assessment of the home, assess the patient and his situation, and come up with a plan of care that the patient can benefit from. Standardized assessments such as the cane, the PIH, instrumental activities of living, compensation scale can also help to determine baselines and to determine outcomes when it comes to early stage dementia and decisions to stay at home or move to a long-term care facility. We also saw that self-care management interventions were not provided to Harold at home. So proofreading is an intervention that should be used, that is used, and it helps with self-management training for patients with mild cognitive impairment. There were too many conflicts and lack of collaboration. So we think that it is important to collaborate, especially in a challenging disease like dementia. Collaborative care models such as the aging brain care medical home model is very beneficial for Harold and people with dementia who want to age in place for as long as possible. Lastly, there was an incomplete interdisciplinary team that cared for Harold, um, and we think that it is important to include as many as possible, all the clinical professionals that can help Harold, such as the physicians, the nurses, the physical therapists, occupational therapists, speech therapists, psychologists, social workers, and caregivers, anyone who can become part of this team, the interdisciplinary team, to help Harold to improve his functional activities that would enable him stay at home for a longer time safely and independently.
Here are some questions to ask yourself to determine if self-management support may be needed for a patient with dementia. 1. Is the patient in the early stages of dementia? Second, is there a self-management support system in place for the patient, such as family caregiver, primary care provider, community resources, social support? Those are some examples of things that make up that support system. Number 3, is the patient in agreement with the plan of care for self-management, and do they have any concerns or questions? Keeping the patient involved in the treatment and at the center of the care is very important. 4, how will you measure if your self-management interventions are effective?
You can find all of the references utilized for this presentation on the next few slides. If you have any questions regarding these references or you would like further sources regarding the topics covered, please reach out and we'd be happy to send you more of the references that we found. Thank you so much for taking the time to listen to and digest this presentation. We look forward to hearing any questions that you have or any comments related to this presentation, and we hope that you have a great day.